Hi Engineers, in this video we're going to talk about potassium-sparing diuretics. Let's go and get started. Hi Engineers, so what we got to do first before we start talking about the mechanism of action of potassium-sparing diuretics is just go over what part of the kidneys we're focusing on, talk about some of the basic physiology, talk about the aldosterone physiology. Then after we get that done, then we can cover how these drugs work, particularly at the cellular level, okay? So where are we focusing on in the kidney? Well, if you guys know, in the kidney, we have a particular part of the kidney, right? So imagine here is our Bowman's capsule, proximal convoluted tubule, the descending limb of the loop of Henle, hairpin turn. Then we got the ascending, there's a thin section, and then there's a thick section, and then the actual distal convoluted tubule, and then we move our way down into the collecting duct. We're going to be focusing on the end of the distal convoluted tubule and the collecting duct. Okay, and why this is important is because this area, it does deal with a small percentage, maybe 3% of the sodium chloride concentration here and water. But this area here, the distal convoluted tubule, this part here, and the collecting duct are dependent upon two hormones. One is ADH, because that controls your water balance, and aldosterone. And this one controls your sodium, chloride, potassium, and water balance. Now, what we need to know is first off, what is the normal physiology that occurs here with respect to aldosterone presence? Then after we do that, then we can cover how these drugs particularly work. So what we're doing is we're zooming in on this portion at the cellular level. So here's going to be our distal convoluted tubular cells and collecting duct cells, and here's going to be a peritubular capillary, okay? So again, here's a little capillary, peritubular capillary, and here there's two cells in the collecting duct and in the distal convoluted tubule that we want to focus on. Okay, this one right here, we're going to call this a principal cell, okay, because this helps to regulate our electrolyte, kind of our ion balance here. Again, here's another principal cell, and we'll see what their relevance is with this whole mechanism. And on the bottom here, we're going to have a alpha intercalated cell, okay? And these help to regulate our acid-base balance. And again, these are distal convoluted tubular cells and collecting duct cells. All right, so now that we understand we have our distal convoluted tubule and our collecting duct cells, we have the peritubular capillaries here. Now, let's talk about how aldosterone plays a role within the normal physiology and then how the drugs work to be able to block the effect of aldosterone or some indirect actions. Well, the first thing we need to know is, where is aldosterone secreted? Well, you know that within the adrenal cortex you have different layers. The top layer is the zona glomerulosa, right? Then after that, the middle layer is the zona fasciculata. And then right around that purple part, there's the zona reticularis, right? And the zona reticularis is basically controlling androgens secretion. The zona fasciculata controls cortisol secretions, and the zona glomerulosa controls aldosterone secretions. Well, we know that this can release aldosterone. Okay, goody. Let's write that out here. Here is the aldosterone. Now we know that aldosterone is secreted, but the thing we should know is that we know that it's secreted by the zona glomerulosa. But what stimulates aldosterone production? That's a key thing here. One of the stimuli, and the most potent stimuli, is going to be angiotensin II production. That's one very potent stimulus of aldosterone secretion. The other stimulus is going to be low sodium concentration in the blood, hyponatremia. And the last one is going to be high potassium concentration in the blood, or hyperkalemia. These are the primary stimulators of aldosterone secretion. Okay? So we know what stimulates aldosterone production. Now, how does aldosterone work in these principal and alpha intercalated cells within the distal convoluted tubule and the collecting duct to control ion, water, and acid-base balance? All right, let's focus on acid-base balance since we're here. Okay? What is aldosterone first off? It's a steroid hormone, right? So it's derived from cholesterol. So does it have the ability to pass right through the cell membrane? Yes. So what happens is aldosterone can move right through the cell membrane. And what it does is it's such a beautiful molecule. Let's put here we're going to have aldosterone. We'll put an A. it's going to bind onto an intracellular receptor. Here's going to be the intracellular receptor for aldosterone. So here's our intracellular receptor that the aldosterone binds onto. Once aldosterone binds onto that intracellular receptor, it's working its way into the cellular nucleus. And it binds on to a specific gene sequence or sequences and stimulates the production or increased synthesis of particular proteins. What kind of proteins? Well, one of these proteins that is really, really important here is going to be this proton ATPase. What is this called? It's called a proton ATPase. What does that mean? Well, what it means is we can take and increase the synthesis of these proteins. Well, what do these proteins do? What they do is they take a proton and it excretes a proton from the tubular cells into the tubular lumen so that it can be excreted out of the body. So we're going to lose protons in the urine. Now this is not so much that it's pathologic. This is just a part of our normal mechanism. But in order for this proton to get pumped out because it's moving against its concentration gradient, we need to utilize energy. And so we take an ATP molecule and we convert this into ADP, an inorganic phosphate. That creates energy that pumps the proton out. So what we know is aldosterone is increasing or revving up the activity of this proton ATPase pump, okay? Now, that's one thing, and that's occurring within the alpha intercalated cells. The next thing we have to talk about is how is aldosterone affecting the electrolyte and water balance? So, aldosterone, again, how does it work? It comes into the cell, right? Because it is a steroid hormone. Once it comes into the cell, here's our beautiful, cute little aldosterone. It binds onto a intracellular receptor. When it binds onto this intracellular receptor, because it is a steroid hormone, it doesn't have to act on the membrane proteins, it then translocates. Where? It gets translocated into the cellular nucleus, and it binds onto a specific gene sequence or sequences that increases the expression of specific types of proteins. What are some of these proteins that it increases the expression of? One of the proteins is this blue protein up here. This blue protein here is a very special protein. And this guy, we're going to write him in that specific color, is an epithelial cell, okay, because these convoluted tubular cells or collecting duct cells are epithelial cells, cuboid in nature. It's an epithelial cell that helps with sodium transport. Okay, so they call them ENaCs. Okay, that's this channel here. So we have one of those proteins that we're increasing the expression of. The other one is we're increasing the expression of this protein here, this maroon colored protein. What is this guy? This maroon colored protein is specific for potassium. So it's a potassium channel. So another thing we're going to be increasing the expression of is potassium channel. So now we're going to have more potassium channels. The last thing it increases the expression of is this purple protein over here. Where's my, there it is. This last one is a very special one, and it has a heck of a name, so we got to extend this a little bit. This is present on almost every single cell in our entire body. These are sodium-potassium ATPases. I know you guys were saying that out loud because we talk about these all the time. Okay, so sodium-potassium ATPases. We're going to increase the expression of that with the presence of aldosterone. Now, we talked about all this darn stuff. How does that even regulate electrolyte and water balance? I'm glad you asked, guys. So, take a look up here. Remember what happened? Things are filtered across the glomerulus into the Bowman's capsule. They move through the proximal convoluted tubule, down the descending limb, around the hairpin turn, up the ascending limb, and then into the distal convoluted tubule. What are some of these things that we're focusing on? Well, in this case, one of them is sodium. And what happens is the sodium ions see this channel, this epithelial sodium channel, and it says, whoo, I can now move from areas of high concentration, because he's in higher concentration outside of this cell, into the cell because there's lower concentration of sodium. So again, the sodium concentration in here is low. The sodium concentration out here is high. But usually there's no channel there because again, the late distal convoluted tubule and the collecting duct are usually only going to have these channels open whenever aldosterone and ADH is present. Well, aldosterone is present, so now this channel opens up or gets increased expression and sodium rushes into the cell. As we increase the sodium ion concentration inside of the cell, where does that sodium go? Well, it comes over here. And what do we say this channel was over here? This was a sodium potassium ATPase pump. And what it's responsible for doing is pumping sodium out of the cell in the interstitial fluid, and then eventually the goal is to get it into the peritubular capillaries. And if you really want to be specific, it pumps 3 sodium ions out of the cell. And at the same time, it pumps 2 potassium ions into the cell. All right, cool. So where'd that potassium have to come from? It had to come from the blood, which then actually moves into the interstitial spaces and then into the cell. So now, because we're having this increased sodium movement, increased sodium potassium ATPase activity, more sodium is coming out here into the blood, more potassium is coming into the cell. Where can this potassium go? Well, we increase the expression of the potassium channels. Well, now what can happen is the potassium can now leak out of the cell because potassium concentration is going to be higher inside the cell and the potassium concentration is going to be lower outside the cell. Where is it going to want to move? From high to low. So this guy is going to move out of the cell. And that means that we're going to lose more potassium. So the overall thing here is you lose potassium in the urine, lots of it, and you gain lots of sodium. Another beautiful thing here that you have to remember is that we assume that ADH is present within these cells, right? And so what that means is that there's going to be aquaporins, right? Type 2 aquaporins that will actually become present. If those type 2 aquaporins are present because ADH is there, what does that mean? Well, where's the sodium moving? What's the direction of the sodium? From the tubular lumen into the blood. Where does water want to follow? From the tubular lumen into the blood. And so the water will follow the sodium into the blood. And so now we're going to have an increase in water reabsorption due to an increase in sodium reabsorption. There is a special name to this. We talked about it in our physiology lectures. And this type of water reabsorption, which is dependent upon aldosterone and ADH, it's not obligatory. It's called facultative water reabsorption. All right, sweet. So we understand that now. So with this all being said, the overall point here is with aldosterone, you get sodium reabsorption, water reabsorption by facultative process, and potassium excretion and proton excretion to regulate acid-base balance. All right, so before we start talking about how these drugs basically block all the effects that we just talked about, I want to make sure that we understand that there are 2 types of potassium-sparing diuretics. Because once we get down the 2 types, we'll understand their mechanisms of action more specifically. You'll see what I'm talking about. There's one group of potassium-sparing diuretics that particularly block aldosterone. So these are solely aldosterone blockers. One is called Spironolactone. And the other one is called Eplerenone. Now, again, I want you to remember these 2 drugs are aldosterone blockers. So I'm going to write that down here on the bottom of this. These are aldosterone blockers. The other ones that we're going to talk about are Triamterene and Amiloride. These 2 are not aldosterone blockers. These block specific transporters. They block the ENaCs, so they're ENaC, and sodium, potassium, ATPase blockers. So we block the ENaCs and the sodium potassium ATPases with triamterene and amiloride, and we block the aldosterone by spironolactone and eplerenone. Now, let's talk about how that will affect these individuals mechanistically. All right, now that we got all of that down, which was a lot, I understand that, let's go ahead and really quickly cover the mechanism of action because it's so simple now. Okay, what do we have here? Let's blast through it, guys. We have aldosterone, right? We released aldosterone. And again, this could be released due to multiple reasons. We said it could be due to low sodium, high potassium, or elevated angiotensin II. It gets into the cell. Here's our cute little aldosterone. It binds onto this receptor here, this intracellular receptor. But what we're going to do now is we are going to give these individuals the aldosterone blockers. So what we're going to do here is we're going to draw here AB. AB. These are aldosterone blockers. And what they're going to do is they're going to inhibit aldosterone from being able to attach to this receptor. And then what? If it can't attach to the receptor, what that means is that less of that aldosterone intracellular receptor complex gets into the nucleus. That means that there is less stimulation of particular gene sequence or sequences, and because of that, there is less synthesis or decreased synthesis of particular transporters. What kind of transporters, you ask? There's decreased synthesis of ENaCs. There is a decreased synthesis of potassium channels. And there is a decreased synthesis of sodium potassium ATPases. And again, these are a mouthful, so let's make a little bit of room for them. You have decreased synthesis of, where's my purple marker? There it is. Sodium potassium ATPases. So because of that decreased synthesis, what does this mean? Okay, let's go ahead and understand this then. The sodium would be flowing through here, right? Let's move this out of the way. Again, it will be flowing through the distal convoluted tubule or the collecting duct. So it's moving through here. So let's make room for it. Make room for sodium, people. Sodium's coming through. Now, there's less of these ENaCs, okay? There's less of them. So what that means is usually when sodium's coming through here, yes, sodium may be in higher concentration and may be in lower concentration in the cells usually. But now, because there's less ENaCs, what that means is that less sodium can get into the cell because there's less transporters for sodium. That means less sodium moves into the cell. If less sodium moves into the cell, remember, what else is the other thing here? There's decreased sodium, potassium, ATPase activity. What does that mean? That means that there's going to be less movement of sodium across this transporter and into the blood. So there's decreased sodium movement because there's decreased activity of this transporter. And on top of that, the potassium that's normally in the blood that moves across the interstitium and into the cell, there's decreased movement of potassium into the cell. On top of that, not only is there less potassium into the cell, but there's less potassium channels to allow for the potassium to exit. So if there's less potassium channels to allow for that little potassium in the cell to exit, that means that very little potassium is going to be excreted, okay? And that means that less sodium is going to get reabsorbed. Now, remember, we assume ADH is present. If ADH is present here, what happens? It increases the synthesis or the expression, more particularly, of these aquaporins, right? Aquaporin type 2. And because of that, water will then move across these aquaporins and into the bloodstream, right? But it follows the sodium by facultative water reabsorption. Well, there's less sodium being reabsorbed. If there's less sodium being reabsorbed, is the water going to follow as much? No. So there's going to be decreased water reabsorption. Now, we got to come back down because we understand that there's decreased sodium in the blood, decreased potassium excretion. Ooh, real quickly. If there's decreased potassium excretion, what does that mean for the potassium in the blood? We're getting rid of less. So potassium in the blood may start to rise. Maybe that's why they're called potassium-sparing diuretics, is preventing me from excreting them and keeping potassium nice within the blood. What do I know, though? All right, last thing. We got aldosterone, right? Again, what else is it doing? It's binding onto this receptor, right? But if we give an aldosterone blocker, it's going to inhibit this attachment. If you inhibit this attachment, that means that less of this complex is going to get into the cellular nucleus, and that means there's going to be less activation of particular genes or gene sequences. That means that less proteins are going to get synthesized, and which proteins are going to be decreased in their synthesis. Guys, it's going to be these proton ATPases. So now because of that, I'm inhibiting the proton ATPases. So there's decreased proton ATPase activity. That means that less protons are excreted. If less protons are excreted, that means more protons could potentially be retained into the bloodstream, right? So less protons excreted means more protons present in the bloodstream. If there's more protons present within the bloodstream, what does that indicate? Could potentially lead to acidosis. Interesting. So we covered the effect of aldosterone on the alpha intercalated cells, right? And we now understand how alpha blockers decrease the proton excretion, which can lead to increased proton concentration in the blood. That's how the aldosterone blockers work. Triamterene and amiloride, let's look back up here. It's very simple now. If we look here, triamterene and amiloride block this transporter. Less sodium gets into the cell, and it blocks the sodium potassium ATPases. Less sodium gets reabsorbed, less potassium gets excreted into the cell, and then because there's less potassium moving into the cell, that means the concentration gradient, right, between potassium in the cell and potassium outside of the cell won't be higher here and lower here in as much of that amount. So what does that mean? That means that less potassium will move from inside of the cell to outside of the cell into that tubular lumen. And that means less potassium is excreted. But we know that if less sodium is being moved across because of inhibition of the ENaCs or inhibition of the sodium potassium ATPases, we know that there's less water being reabsorbed as well. And we know that because less potassium is moving into the cell, less potassium is getting excreted. We know that there's also that effect. But does triamterene and amiloride affect the proton ATPases? No, because they don't affect particularly aldosterone's effect on the receptors in that area. Okay? Now we understand the mechanism of action. All right, so now that we understand the mechanism of action and all those intricacies that we talked about, let's talk about what we can use these drugs for. One of the big things, and it's really straightforward, what if somebody is blasting out large amounts of aldosterone from a tumor in their adrenal cortex? So they're just blasting aldosterone away. So the aldosterone levels are super high. In that situation, then wouldn't these drugs actually be pretty beneficial? What is this condition called when someone has a tumor of their adrenal cortex, a primary tumor that's blasting out aldosterone? This is called Conn syndrome. Okay. Another term that you might hear is hyperaldosteronism. But again, this is called Conn syndrome. And this would be a super beneficial time period to utilize aldosterone blockers, particularly spironolactone and eplerenone, because they block all the effects of aldosterone. So with that being said, in situations where someone has, what do we call this? Hyperaldosteronism. maybe secondary to Conn syndrome, this might be a beneficial time to utilize aldosterone blockers. All right, the next thing I want us to understand here is that you guys realize that we've talked about thiazide diuretics and loop diuretics. And we know that because these drugs can decrease sodium and water reabsorption very, very minimally, they're not really the best for fluid overloaded states. However, remember there was a drug that we utilized in patients who have what's called maybe pulmonary edema. And that pulmonary edema, which is the fluid that accumulates within the interstitial spaces of the lungs, could be due to CHF, could be due to nephrotic syndrome or AKI, could be due to cirrhosis. They may have peripheral edema, and that peripheral edema may be due to, again, CHF, maybe more particularly right-sided heart failure, maybe ascites, maybe due to nephrotic syndrome or AKI, or they could have a pendulum like abdomen due to ascites, and that ascites could be due to, again, cirrhosis, liver failure, right? Could even potentially be due to right-sided heart failure. But regardless, we said whenever we want to pull off that excess fluid, so in other words, we want to pull all that excess fluid, whether that be excess fluid from the pulmonary circulation, excess fluid from the lower extremities, excess fluid from the peritoneum, we want to pull that excess fluid out of the body, right? And then bring it through the kidney tubules. What was a drug that dealt with 25% of our sodium chloride and even some of the water in the thick ascending limb of the loop of Henle? Loop diuretics. And loop diuretics can pull off an excessive amount of water. So you're trying to pull some of that fluid off. It's going to pull off some of the excess sodium. It's going to pull off some of the chloride. But what else does it undesirably lead to, you excreting? Potassium. So you can lose potassium with loop diuretics, right? So wouldn't it be great whenever you're giving somebody a loop diuretic, right? So let's say that you're giving somebody a loop diuretic. We said that this can cause hypokalemia. What if we give a particular drug class that would basically decrease the excretion of potassium? And this is where we could utilize potassium-sparing diuretics. Because what they're going to do is they're going to help to increase the potassium. And maybe the goal out of both of this is we'll be able to maintain a normal potassium balance. Isn't that cool? So in edematous states, okay, so when someone is having basically their fluid overloaded, and you're treating them with a loop diuretic, which can potentially cause hypokalemia, give them a potassium-sparing diuretic in addition to that loop to prevent excessive potassium loss. Pretty cool. In addition, remember, this acts in the distal convoluted tubule and in the collecting duct. And what do we say it basically can do? It can decrease sodium reabsorption and decrease water reabsorption. If you decrease sodium reabsorption and you decrease water reabsorption, what do you do to the blood volume? You decrease the blood volume. And if you decrease the blood volume, what can that lead to? A decrease in blood pressure. So what other conditions could these drugs be utilized in, especially maybe in combo with another medication? They could be utilized in hypertension. Now, because they don't deal with a large volume of sodium and chloride, sometimes with hypertension, we combine things like triamterene or amiloride with like hydrochlorothiazide. So sometimes a common combo that you'll see here for hypertension is you take a hydrochlorothiazide and combine that with a potassium-sparing diuretic. Because these also, HCTZ, can also lead to hypokalemia. So you get that added benefit of a little bit less sodium water reabsorption and preventing the potassium drop. Isn't that cool? All right, another really interesting indication for these these potassium-sparing diuretics, and it's actually been shown to decrease mortality in individuals who had post myocardial infarctions. So let's say here some individual had a MI, right? So they're post MI. And let's say that it was of their left ventricle. So post MI, we'll say left ventricular MI. After they've had that myocardial infarction, right? The infarcted cardiac tissue gets replaced with fibrous tissue. Okay? Now, because of that, what happens to the pumping function of that left ventricle now after you've had a significant MI? Let's say that this was an anterior MI, so it took out a good pumping function. As a result, post-MI, they're going to have a decreased cardiac output, right? If there's a decrease in cardiac output, what does that lead to? That leads to a decrease in blood pressure. Okay, where are you going with this, Zach? Watch. If there's a decrease in blood pressure, what this does is it stimulates those receptors. Remember you had those receptors that were present in the aortic arch and also at the bifurcation of the common carotid artery, right there you had the carotid sinus and the aortic sinus. We're just going to look at the aortic sinus for right now. Those baroreceptors that are located within those sinuses are stimulated, right? So we stimulate these bad boys. Then what happens is they send signals to a particular area of the brainstem in the medulla. And then when it activates the medulla, it activates the sympathetic nervous system component. And what that does is it increases the release of norepinephrine. That norepinephrine, which is due to increased sympathetic nervous system activity, does a couple things. One of the things it does is it tries to increase the heart rate. It tries to increase the contractility of the heart, okay? And we're going to see how that affects the heart here in just a second. The other thing that it does is it activates the JG cells in the kidney. So it acts on the kidney, remember? It has those beta-1 receptors, because this is a beta-1 receptor. This is a beta-1 receptor that are present on the contractile cells, beta-1 receptors on the non-contractile cells, and beta-1 receptors present on the JG cells of the kidney. And it increases the release of renin. Renin then does what? Well, it increases the activity of angiotensin II. And angiotensin II basically increases your total peripheral resistance, right? By causing intense vasoconstriction. And that causes some stress onto the heart. The other thing is that angiotensin II also increases ADH and increases aldosterone production. And these two increase sodium and increase water retention. If you increase sodium and water retention, that increases the blood volume. And as you increase blood volume, you increase the preload. With increased total peripheral resistance, you increase the afterload. With increased heart rate, increased contractility, that increases the stress on the heart. And that increased stress on the heart is going to lead to cellular adaptation. And that is going to affect the actual myocardial cells. What in the heck does all this mean? Let me explain. If you increase stress on the heart, right, because you're increasing the heart rate, you're increasing the contractility, that's causing them to have to work harder. That's consuming more oxygen, and it's increasing their oxygen demand. How are the cells going to have to respond to that increased oxygen demand and therefore decreased supply? Well, they're going to have to adapt, and they're going to try to become bigger. They're going to hypertrophy. So one of the effects of that is it's going to cause the myocardium to become thick and larger. The other thing is, with increased angiotensin II production, that causes vasoconstriction of the arterioles and increases the afterload. That causes the heart to have to work harder. And if you increase the stress on the heart, it's going to have to work harder, it's going to have to pump harder to generate higher pressures to push blood out of the ventricles. That's going to lead to the cells having to adapt to that, and it's going to undergo hypertrophy. So one of these things that can happen here is what's called ventricular hypertrophy. The other thing that you have to understand here is that if we increase the production of aldosterone and we increase the production of ADH, we get more water retention, more blood volume, more preload. That's going to stretch on that myocardium. And because it's going to stretch on the myocardium, that's going to cause some cellular adaptation. And instead of it hypertrophying, it causes it to grow in what's called a series pattern, and it causes the ventricles to undergo this dilation mechanism. And so because of that, the ventricles undergo dilation. This process of where the myocardium can undergo ventricular dilation or ventricular hypertrophy due to this entire mechanism we talked about after a myocardial infarction is called cardiac remodeling. If we give a drug like a potassium-sparing diuretic, what are we going to do? We're going to block the effect of aldosterone. If we block the effect of aldosterone, we block sodium and water retention. We decrease a lot of that blood volume. We decrease the preload on the heart. We decrease the cells having to adapt in response to that, and we decrease the effect of ventricular dilation after post-myocardial infarction. This is one of an amazing, amazing functions of these drugs, especially if someone develops heart failure because of this severe MI. Beautiful mechanism. The last thing that I want to talk about with the potassium-sparing diuretics, and it's very interesting that they found out how these work, is one of the things that we have to remember is that these drugs, particularly spironolactone and eplerenone, so let's write these down. Spironolactone and eplerenone, they can basically block the effect of not just aldosterone, but also androgens in general. You know, androgens are steroid hormones, just like aldosterone. And what happens is they have to move into cells through that cell membrane and bind onto a receptor, which produces its overall cellular effect, right? So let's just say overall cellular effect. Well, if we give these drugs, we basically block the androgens from binding into their receptor, and we decrease the cellular effect. This is important when it comes to certain conditions where elevated androgens can cause pathological conditions. What's one? One simple one is when someone has too much testosterone. They got increase in the test, like polycystic ovarian syndrome. And polycystic ovarian syndrome, they produce too much testosterone. If we give them spironolactone, we block the effect of it. If we block the effect of it, we decrease overall increased testosterone levels, which causes hirsutism, right? It causes alopecia. It causes male type of it causes masculinization processes, right? Where they have increased hair growth. They have all these oily skin problems, and they even can develop diabetes, okay? Insulin-resistant diabetes. So this is one of the benefits. Another thing is that they found an androgenic acne. So people who have androgenic acne, these drugs have also been effective in helping to block the androgen effect. All right, so now what we got to talk about is the potential side effects and adverse drug reactions that we should be aware of with potassium-sparing diuretics. I'm going to list 3 here, and then we're going to talk about them. The first one that I want you to remember is that these drugs have the potential of causing hyperkalemia, and the mechanism is going to make so much sense. If not, we've already beat it like a dead horse so far. And if not, the name is potassium-sparing diuretics. So hyperkalemia is going to be a potential side effect of this drug. The other thing that I want us to talk about is that there is the potential of metabolic acidosis. Okay, and we'll discuss that. And the last thing I want to talk about is more specific to one of the potassium-sparing diuretics. And that is that they can potentially produce kidney stones. Okay, so kidney stones, and this is specific to Triamterene. Okay, which is one of those potassium-sparing diuretics that blocks the ENaCs and the sodium-potassium ATPases. So how does it cause hyperkalemia? How does it cause metabolic acidosis? And again, the kidney stone aspect, we don't actually know the underlying mechanism of it. But again, I just want you to realize that that is a potential side effect. All right, so how does it cause hyperkalemia? We understand that basically we're blocking the effect of aldosterone, or we're blocking the sodium-potassium ATPases, we're blocking the ENaCs, and we also have to talk about these potassium channels, right? Well, remember, what do we know? We know sodium moves into the cell, right? And we know that in order for it to get out of the cell, it needs the sodium-potassium ATPases. And potassium moves into the cell as sodium moves out of the cell. And then again, potassium exits the cell via these potassium transporters. Well, if we give drugs that block aldosterone, which helps to enhance all of these processes, right, what's going to happen? We decrease sodium reabsorption, we decrease the activity of the sodium-potassium ATPases, we decrease potassium entry into the cell, and we decrease potassium excretion. So what does that mean then? And instead of excreting potassium, we can accumulate potassium. Okay? So that's one of the big things. On top of that, one thing you have to remember is, would we want to be very, very careful of giving this drug, potassium-sparing diuretic, with ACE inhibitors and ARBs, because what do? They inhibit the action of angiotensin II overall. What's the stimulus for aldosterone production? Angiotensin II. So these drugs could potentially block aldosterone indirectly and lead to the same effect. So you have to be careful, be very cautious when utilizing ACE inhibitors or ARBs with potassium-sparing diuretics. The other thing, we know that aldosterone works on those alpha intercalated cells, right? And what does aldosterone do? When it acts on those alpha intercalated cells, it basically is going to help to stimulate the proton ATPases, okay? And if we give an aldosterone blocker, particularly spironolactone or eplerenone, we block the activity of the proton ATPases. And that means that less protons are excreted into the urine. And therefore, protons accumulate in the blood. Because if we're excreting less, we're retaining more. And that is the potential of this drug in higher concentrations. And again, what do we already say? We know that Triamterene has the potential, and we don't know exactly how, but we know that Triamterene can produce kidney stones. So again, remember that there is the potential of kidney stones with Triamterene. Another thing is that we can actually induce an acute kidney injury. So there could be the risk of AKI when utilizing NSAIDs in combo with Triamterene. So this is another thing that you have to be very cautious of. All right, now we understand that it can cause hyperkalemia, metabolic acidosis, kidney stones, and AKI if you use Triamterene with NSAIDs. The most concerning of all of these side effects is the hyperkalemia. Why? What you want to remember is that high levels of potassium can cause cardiac arrhythmias that can become potentially fatal. What are some of the things? If you checked an EKG, if you got a 12-lead EKG on this patient, what would be some of the things that would pop up? I know a lot of you are saying it at home right now. Oh, peak T waves. Absolutely. That's one big one. That's probably one of the more common types of things that people will say. But there's a lot of other things that you can see beside peak T waves. Another thing that we could see is that the PR interval could be much longer. So there could be what's called a prolonged PR interval. Another thing, and actually let's be specific, that's the PR segment. Here is our PR interval from the beginning of the P wave all the way until we get to the QRS complex. The other thing that we have to remember is not just prolonged PR interval, but look at this QRS complex. Look how wide that son of a gun is. That's a wide QRS complex. So that's another potential sign that we can see here, a wide QRS complex. We say that technically if we want the length, it's greater than 0.12 seconds. The other thing that we can potentially see here is that sometimes you can have some ST segments that are depressed. So sometimes you can even have what's called ST segment depression. The most dangerous. So again, we got peak T waves, we got the wide QRS complex, prolonged PR interval, ST segment depression, but the most dangerous and one of the scariest things is that you can see signs of ventricular fibrillation. Okay? And usually it starts off presenting in what's called a sine wave pattern on the EKG. Okay? So hyperkalemia is characterized as anything greater than 5 milliequivalents per liter. So you want to make sure that you're checking BMPs to see if this person is having an elevated potassium level. The last thing I want you guys to remember is, remember we talked about how this has anti-androgen-like effects? Well, in males, if you have anti-androgen effects, you decrease testosterone. That could potentially, because testosterone plays a role within spermatogenesis, it plays a role within the erectile activity. This could lead to erectile dysfunction in males. So the pecker ain't working. And the other thing is it can actually not just cause erectile dysfunction, but maybe even decrease sperm production. So that's another issue that can arise. The other thing is it can cause gynecomastia. What is gynecomastia? Moobs. So it's when dudes get moobs, all right? They get breast tissue. That basically they're enlargement of the tissue around the actual breast, and that's going to cause gynecomastia. So that's some things that we could worry about here when it comes to the anti-androgen effects. And again, you're going to see this more commonly with like spironolactone. Okay? So not only does it have anti-androgen effects on males, but if females take this drug, they can also have that. And because it can alter the normal estrogen levels, the progesterone levels, it can alter the menstrual cycle. And it can potentially lead to no menstrual cycle. And this is called amenorrhea. Okay? And so these are some of the potential side effects or adverse drug reactions that we should watch out with potassium-sparing diuretics. All right, Ninja Nerds, in this video we talked about potassium-sparing diuretics, and I know we talked about a lot of it. I really hope this made sense. I really hope that you guys did enjoy it. I know it was long, but I really appreciate you guys sticking in there with me, and I hope this stuff really does make sense. If it did, please hit that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, down in the description box, we'll have links to our Facebook, Instagram, and even our Patreon account, as well as our GoFundMe page. If you guys want to go check that out, we truly appreciate it. As always, Ninja Nerds, until next time.